having me. The SHOCK 2 study results have contributed to a change in practice in some centers, but not all, and seeing a decrease in balloon pump usage. And the biggest question to come out of this is why? Why have some centers changed their practice and others haven't? Now, as a result of the study, there have been a lot of continued discussions, which we all know, I'm sure you're having them in your facilities as well, about the role of the balloon pump and its efficacy with cardiogenic shock. Now, the conflicting responses, excuse me, but the conflicting responses to the trial do lead to the question asked by many of us, so what or now what? Now today we're going to go through the current state of the science of balloon pump therapy and review some expert opinion on SHOCK 2 and why the results are not necessarily that shocking and not that earth-shattering. Now, almost every recent randomized clinical trial, RCT, done in cardiology over the last, I'd say, 5 to 10 plus years, has really not shown a whole lot of benefit for the balloon pump, at least in the short term, and short-term outcomes are going to be defined as in-hospital or less than 30-day outcomes. Now, the trials, however, have had high levels of crossover, indicating that the clinician believed at some point for that specific patient, the balloon pump would be beneficial for the patient. Now, most of the studies, again, did look at short-term, but it is well known what early mortality in cardiogenic shock, it is high. We all know that, we see it. Now, this does lead to a number of patients dying before therapy can ever be instituted and really seeing the therapy support from a balloon pump. Now, from a historical perspective, balloon pump therapy has continued to be used for more than 45 years. This does lead to the question, have we been wrong about the benefits for all of these years, or has the focus on mortality and adverse events alone been incorrect in the face of the adjunctive nature of the therapy of balloon pumps? Most of the evidence for balloon pumps has come from non-randomized trials, which don't always directly compare the results of a group of patients, similar type of patients who have had balloon pumps and who have not been treated with balloon pump therapy. So that does mean that the strength of the evidence is less, statistically. But interestingly, all of the recent trials have concluded that balloon pumps are safe, which is a surprise, although a good one, so it does make the risk of using balloon pumps for our patients minimally low. So the question is, where does this leave us with a balloon pump? And two main reviews that we're going to go through here, sorry, I keep forgetting I have a different clicker up there, is that where does this leave us with a balloon pump? Is it time to just abandon ship, or is there salvageable pieces to this? And have we given up on it completely with cardiogenic shock patients post-MI? So we're going to do some review here, and the scientific literature does provide strong support for the physiological benefits of balloon pump therapy. Now, this is all things that we know. We know why we use balloon pumps, with a coronary perfusion, afterload reduction, improved hemodynamics, LV performance. It's all of those things that we know. We know that that's what a balloon pump is designed to do. Now, while outcome studies have conflicting results on mortality, the efficacy of the balloon pump has been well demonstrated, especially in respect to improvement of hemodynamics. So why then do these randomized clinical trials not show us the benefit that we still see in our patients? Now, it is important to remember that millions of patients have been treated with balloon pump over the time it has been in use. But randomized clinical trials really only take a snapshot of a few thousand of those patients. So we have to truly wonder if that is enough evidence to overturn the experience and clinical success we've all had with balloon pumps in our patients. In addition, with more meta-analysis, when they are done, combining those RCTs together and looking at that data as a whole, it becomes more clear that the RCTs are typically underpowered and therefore unable to detect the differences in outcomes due to balloon pump use. Since balloon pump is an adjunctive therapy, it is understandable that balloon pump alone is not likely to change mortality without other appropriate treatment modalities. It has to have other pieces to that puzzle. It's a good piece to the puzzle, but we all know it is just a piece in treating that patient overall. Now, when RCT data is combined using meta-analysis, the benefits of the balloon pump are more often shown. This may indicate that all RCTs out there are underpowered to detect that real treatment difference. And it is critical to remember that a negative result in an RCT may not reflect an actual lack of benefit for a particular treatment. So meta-analysis do favor balloon pumps in thrombolytic therapy, pre-op use, and there are, again, mixed results with high-risk PCI and cardiogenic shock, but there is still some benefit there. Now, with that being said, all of that, balloon pump is one of the most studied technologies that we have available. And in our database alone, we do have reviewed 2,000 papers, which include almost 800 studies, which have more than 236 balloon pump patients and 1.4 million patients acting as our control group. And more than half of the data has been generated in the last 10 to 15 years, which indicates that there is that current interest in balloon pump therapy and really trying to understand maybe a little bit further. Now, the criticism of balloon pump by some is that most of the evidence is based on registry and non-randomized data, so proof of effect is less strong, like we've talked about. This means it is difficult to make definitive clinical recommendations on when to use the balloon pump and which patients will have a greater benefit than risk. A publication by Colt in 2014 on the trends of incidence, management, and outcomes of cardiogenic shock in the US shows that the balloon pump usage has increased in the last decade. Early use of the balloon pump, so prior to revascularization, did increase at a slightly higher rate than overall increased use of balloons in 2010 especially. Now, what we also see here are some patient characteristics related to balloon pump use. And conclusions are going to tell us that the incidence of cardiogenic shock complicating STEMI has increased during the time frame considered, combined with an increased use of early mechanical revascularization and balloon pumps. There has been a concomitant decrease in risk-adjusted in-hospital mortality, but an increase in total hospital costs during this period. So really, again, goes back to that question of so what or now what? Should we care about these negative results and change our practice as a result of them? And if we do, what do we do with a patient who is in shock since no other alternatives exist which demonstrate improved outcomes at the same level of risk as a balloon pump? Now here, this is just a quick summary slide of levels of recommendation for balloon pump use in various clinical conditions, which we all see and are kind of used to. And in general, the support for using a balloon pump in these patients is moderate to strong. The next thing we're going to start into is shock 2. So we want to do a quick review of the trial in and of itself, and it was a trial involving 600 patients, and it was randomized to a balloon pump group and a non-balloon pump group for cardiogenic shock following AMI and planned revascularization. Now, the primary endpoint was looking at 30-day all-cause mortality using the intention to treat principle, and the way the study was designed, there were a lot of secondary endpoints that were also able to be considered and then collected. Now, the trial was well done as a whole, and it was the first and largest randomized trial for balloon pump patients with cardiogenic shock. The trial was designed to address issues such as crossover between treatment groups and collected a wide range of data so that a significant amount of subgroup analysis, again, could be performed to try and gain as much information on the impact of balloon pump therapy for this patient group. And although there were 37 centers total included in Germany, 7 centers accounted for the majority of the patients in the study, and 2 centers accounted for the large majority of the patients enrolled. This raises the question of whether the study reflects all patients in cardiogenic shock, or more specifically, the practice of these centers. Although this study was well done, the trial was well done, it may still not tell that whole story that we need to consider. Now, a number of issues have been identified by experts that are important to consider when determining how to use the results of the trial for changes in practice. For example, the baseline mortality rate was much lower than predicted, bringing into question if the study really included the sickest of the sick patient, who we all know benefit the most with balloon pump support. And secondly, most insertions were done after PCI intervention, even though prior studies have indicated that the primary benefit with balloon pumps is when we use it before PCI. Third, groups such as those with mechanical defects were completely excluded due to the known benefits of balloon pump support in those patients. And finally, door to balloon time, and this one's pretty interesting. Standard door to balloon time, we all know, is 90 minutes. That's the goal. And typically, the average is anywhere from 82 to 84-minute range for door to balloon time. In shock 2, the door to balloon time was less than 46 minutes. So that's a huge change in what the normal standard is out there and what we probably all have in our own facilities. So the early treatment may also make it difficult to generalize the findings of this study to other centers because that door to balloon time is significant when you think about that. We all know time is muscle. Now let me go down one more here. Now, the view of the experts who have reviewed the trial concluded that the 4 issues make it difficult to generalize the findings of shock 2 to all patients. Number one, it was underpowered. The sample size was based on a predicted 30-day mortality of 56%. Well, the actual mortality in the control group was 42, which would have required a sample of over 900 patients to get statistical difference and really detect that treatment benefit. And again, we only had that 600. Secondly, large amount of crossover from non-balloon pump to balloon pump did occur. Crossover, we know, can dilute the difference between the treated and non-treated groups, making it harder to detect that treatment effect and the benefit. Now, patients who did cross over to the balloon pump had significantly improved outcomes. So those in the non-balloon pump group, death occurred in 11 of the 13 when they did not cross over to a balloon pump, so 85% death. And in the group that did cross over to a balloon pump, we saw only about a 40% death rate. So it did drop significantly when that balloon pump was added and they did cross over to that mechanical support. Now, timing of balloon insertion, 86.6% of the patients received their balloon insertion post-PCI, post-intervention, even though, again, we know that pre-insertion does have more effect to the patient. And planned follow-up here might be a little bit short. So what SHOCK 2 did is it really looked at that shorter time frame to see of outcome improvement. And the current planned follow-up at 6 and 12 months may not be long enough to really give us that view of treatment benefit. Now, BCIS-1 followed up demonstrated a mortality benefit at 51 months. So it's greater than 4 times the length of the follow-up time. And that was not visible. What they saw at 51 months as improvement, they did not see any change in that same subset at 30-day. So even though we had no change in improved outcome at 30-day, at 51 months, there was a marked improvement. Now, the authors recommend extending the follow-up period to see if treatment benefit does emerge over time. It does take time sometimes to see that impact. Now, recent meta-analysis by Chen in 2013 demonstrated a long-term benefit, so greater than 6 months, with a balloon pump despite no improvement in the 30-day benefit. Now, SHOCK 2, this one just kind of is going to go through what it just kind of echoes what we just went through. And some other key points were made in this review that really look at globalizing the results of SHOCK 2 to every single patient post-AMI in cardiogenic shock. Now, time intervals from chest pain onset or AMI recognition to revascularization to enrollment to balloon pump were not provided. So we don't know what that time frame was. And the timing of the balloon use and duration of ischemia are known to impact outcomes for all patients. Again, 86.6% of those patients enrolled had the balloon pump, had it post-PCI instead of pre. And one of the really interesting things to me was the fact that in the balloon pump group, 4.3% of those patients that were enrolled in the subgroup of balloon therapy never were put on a balloon pump. So 4.3% of those patients never even got a pump. Over 17% of the patients did cross over to the balloon pump side, most within the first few hours after study enrollment. And LVADs were also used in the, when necessary, and that further dilutes, again, the results. Now, type, size, and insertion methods for that balloon were not provided. So device types, sizing of the balloon, things like that were not recorded, nor was the efficacy of the pumping. So we have no idea what the kind of augmentation was, what the unloading results were for these patients, because that was not put into the criteria of data collection. Now, follow-up is limited at the time of discussions. The final 12-month data mirrored the results of the initial 30-day, showing no benefit to balloon pumps. Now, as a result of the fact that most balloon pumps were used post-PCI, the authors concluded that the results could not be extrapolated to use for the pre-PCI balloon pump. They also point out that balloons have a favorable effect on mortality in patients younger than 50. So using these balloon pumps did seem to have more of an impact in our younger patient population in this meta-analysis. Now, they concluded the balloon pump should remain the first line of mechanical circulatory assistance for hemodynamically compromised patients with or without cardiogenic shock undergoing primary PCI. So early upgrade, obviously, again, to more advanced devices should be considered for suitable candidates who remain in refractory cardiogenic shock, despite the revascularization and potential balloon pump use, balloon pump support. Now, 2 earlier randomized clinical trials with Pereira and then Patel looking at BCIS-1 and CRISP AMI. These did have similar findings at the end of the trial, that is that the balloon pump did not improve outcomes. However, BCIS-1 followed patients for up to 51 months and found a 34% mortality decrease in the balloon pump group. The primary reasons were thought to be due to the reduction of reischemia rates and the reduction of the development of heart failure or shock. They also concluded that the balloon pump should be on standby for high-risk PCI patients and is beneficial in stabilizing patients with hemodynamic compromise. Now, CRISP AMI did not demonstrate, what it was really looking at is that reduction in the size of the MI, the infarction. And it didn't really demonstrate a reduction in the size in the balloon pump group as compared to the control group, but all-cause mortality was lower at 6 months in the balloon pump group. Now, the groups were small with CRISP AMI for really any kind of meaningful comparison, but we did see that trend. And a key finding of the study was that the insertion of the balloon pump did not increase door-to-balloon time. So doing a pre-insertion prior to intervention of a balloon catheter did not lengthen door-to-balloon time. Now, SHOCK 1 trial did indicate that early revascularization was the most important factor to outcome, we're not shocked by that, which makes sense as revascularization is the primary treatment. But as a result of SHOCK 1 trial, many clinicians did move away from early balloon pump use in favor of faster door-to-balloon times. But CRISP AMI does show us that we don't have a lengthening of that door-to-balloon time when we're using our balloon pumps pre-PCI. So there's no change in that. Now, both BCIS-1 and CRISP AMI demonstrated that the balloon pump was safe and that in the longer term, there was a benefit to be seen from balloon pump therapy. This is thought to be due to reducing the changes in the ventricle or the negative remodeling after AMI, which obviously is going to preserve ventricular function for our patients. Now, both studies concluded that high-risk PCI with hemodynamically unstable patients should have access to a balloon pump. So it should be available to the clinicians to make that decision when necessary with that certain population. Now, Chen, we're going to go over meta-analysis here, and Chen performed this in about 2013, and he reviewed studies on patients receiving balloon pumps with contemporary revascularization in patients without cardiogenic shock. So here we're looking at PCI and thrombolytic type patients. Now, 10 studies were included with over 2,000 patients and compared at 30-day mortality and greater than 6-month mortality. Now, the key findings was that early mortality at 30-day was not reduced by balloon pump. The longer-term mortality and adverse events were both reduced significantly. The authors concluded that most individual studies are underpowered, like we already talked about, to detect the treatment difference, but when they're combined, that's when we start to see the differences. Early mortality was not reduced in the balloon pump group as compared to the no balloon pump group in the early mortality, again, that 30-day. Long-term mortality was significantly reduced in the balloon pump group as compared to the non-group. This effect was more pronounced in the patient subset being treated by percutaneous intervention. Now, balloon pumps were associated with a reduced risk at 30-day reischemia rates and the composite outcomes of reischemia and heart failure rates. It represents a 25% risk reduction in adverse events with using a balloon pump. Now, the conclusion of this meta-analysis is that balloon pump can improve long-term survival when used in high-risk patients undergoing contemporary perfusion strategies, so PCI and thrombolytic, and was more important with the PCI groups. Now, further, it explains some of the reasons why other studies, such as SHOCK 2, did not show a benefit. Chen's meta-analysis included patients undergoing PCI and excluded patients in shock. Both short and long-term results were included. But does this mean that we can ignore SHOCK 2? Well, of course it doesn't. But the experts' review by others, along with the findings by Chen, do provide a more comprehensive view of the benefits of balloon pump than SHOCK 2 alone gave us. Given that SHOCK 2 is underpowered to detect a difference between the groups, it is possible that a significant effect exists in the shock patient, but the study just wasn't big enough to really detect the difference and be able to demonstrate that statistically. A key finding in all of the contemporary studies, again, is that the balloon pump is safe. There is no significant difference in complications between the groups, and it's an important finding as it supports what we all kind of know is that it is a low-risk type of therapy. Balloon pump does have a low-risk nature with its association. Given that there are a few other alternatives to provide hemodynamic support, it seems that the response to SHOCK 2 should be, so what, not now what. There is still a need for studies that more clearly help clinicians to determine when a patient will benefit from balloon pump support so that they can determine when to best use it, but for now it is still one of the most effective therapies and ways to support hemodynamics without the added burden that occurs with the high-dose drug therapy that we've all seen and experienced with our patients. Now, this slide summarizes key points about why the balloon pump therapy still matters, why it's relevant, and this is, again, everything that we see, why we use a balloon pump still. You know, we do have that buying time to support the patient and to support the hemodynamics until definitive strategy can be decided upon. It's safe and easy, it's widely available, it's cost effective. So these are all the reasons why it's still there. After 45 years, we are still using it. Now, this slide summarizes key indications for which there is strong support for balloon pump use. Now, with regards to pre-op balloon usage, so more into our world now. So pre-op balloon usage, in a meta-analysis from 2012 that performed a systematic review of prophylactic balloon use for high-risk patients undergoing coronary artery bypass surgery, a reduction in hospital mortality and length of stay was noted with balloon pump usage. The meta-analysis supports the prophylactic use of balloon pump to reduce hospital mortality and also supports prior meta-analysis done, all of which showed a benefit of pre-op and prophylactic use. Now, Daniel in 2009, you can see up here, did a long-term follow-up study of the prognosis of patients undergoing cardiac surgery treated with balloon pump. Now, this study was 154 patients over a 15-year time span, showing a decrease in predicted 30-day mortality with balloon pump use. Now, cumulative 1, 5, and 6-year survival was also higher in the prophylactic balloon group, patients who were hemodynamically stable with balloon, than the vital indication balloon group, so patients who were hemodynamically unstable and on maximum inotropic support. So you do see that benefit of that pre-op early insertion. With balloon pumps for support of patients with mechanical defects after AMI, Shock 1 supported the use of balloon pumps to reduce mortality before surgical correction of the mechanical defects associated with those AMIs. And Kettner in 2013 demonstrated a 50% decrease in pre-op mortality for patients in CS due to the mechanical complications after AMI with balloon pump versus no balloon pump. And another mainstay for balloon pump therapy is with unstable or refractory angina. Now, studies done in the late 70s clearly demonstrate a reduction in ischemic events with balloon pump use, and these are still considered the defining evidence for this condition, for that angina and refractory things. Now, evidence summary from key studies in support of balloon pumps. So now we're going to go into further documents and further trials that are showing us that yes, a balloon pump is beneficial in these cardiogenic shock patients, acute coronary syndrome, prophylactic balloon pump usage. Now, these following well-controlled and broad meta-analysis studies reached different conclusions on the impact of balloon pumps on outcomes. Now, in patients with cardiogenic shock from AMI, Cheng concluded that a balloon pump improves 30-day survival, which obviously is a key measure of effectiveness. 70% of patients here were able to be stabilized with a balloon pump when drug therapy failed. Early intervention and use of a balloon pump was an important aspect in the single-center trial, and the study also provided one of the few pieces of evidence on long-term results ranging from 0 to 15 years. The study provided long-term survival data for patients who survived until balloon pump was removed for 1, 5, and 10 years. And survival rates, respectively, were 69%, 58%, and 36%. So the authors here concluded that in addition to improved short-term survival with balloon pump, an encouraging number of patients are surviving in the long term because of that therapy. Now here we're going to look at the conclusion that early use of balloon pump for patients undergoing high-risk PCI due to cardiogenic shock improves in hospital outcomes. Now, chemical markers of ischemia here in infarction were reduced in balloon pump patients and support other studies which do conclude that preservation of myocardial function is key to improving survival and long-term outcomes. This study also supported early use of balloon pumps, specifically balloon insertion prior to PCI. Early use of balloon pumps prior to PCI has been associated with a reduction in major adverse cardiac and cerebrovascular events during or after PCI. So it helps stabilize that patient during that high-risk procedure. Now here we're going to look at the use of balloon pump for AMI with or without cardiogenic shock. In this meta-analysis of 16 balloon pump trials included a larger number of patients than Shock 2 and was able to discern a benefit in AMI patients with cardiogenic shock. Now, patients with moderate hypotension showed no benefit. Moderate hypotension here is defined as systolic BPs 90 to 100. Now, this is an important study because it may help to explain the findings from SHOCK 2. In SHOCK 2, the patient population had typically a moderate hypotensive type of patient presentation. It is relevant to SHOCK 2 because the hemodynamic profile presented in the study seemed to indicate that the patient was maybe not as severe as expected to be enrolled. Both systolic BP and overall mortality rates were higher or lower than expected for the cardiogenic shock population. It is possible that the study demonstrated that patients with less compromised hemodynamics may not have the same benefit as those with significant hemodynamic impairment. So the sicker the patient, the more impact they're going to feel. This analysis supports the use of the balloon in a sicker patient population and hypothesized that this group may experience that greater benefit to therapy. Further supports findings by Schroeder in 2005 and Chung in 1996, who found that patients with the worst LV function do have the most improvement from balloon pump therapy. One further, in this study here, Ranucci looked at the impacts of the peri-op use or pre-op use of balloons in patients undergoing cardiac surgery in the presence of heart failure. Now, this study showed that early use of balloon pumps may reduce adverse events and high-dose inotropes, which we know can increase cardiac work and therefore lending towards that drug-refractory heart failure. Now, although this study was retrospective in nature, it did show a benefit to earlier balloon usage in this patient population. Last one here, LaRusso also concluded that earlier use of balloon pumps were beneficial, particularly in respect to preserving LV function, which we all know has been shown to improve long-term outcomes. And the authors stated that a balloon pump use enhanced peri-op management. You've all seen that patient coming in, pre-op balloon. It's easier to go through that case sometimes because you have that added support of the balloon pump when you're trying to come off pump to get them into the unit. Last year, what we are all saying still about balloon pumps, we all still hear this in our facilities. It's safe, it reduces mortality, it enhances that peri-op management. We have yielded the best outcome when we have a balloon pump. We have that crossover group that sometimes we have to add the balloon pump down the road because we've maxed out on our inotropic supports. And really, to summarize, balloon pump is the first and highest used mechanical assist device due to its safety profile, ease, and use of availability. It is also cost-effective, low risk, and other devices, including Impella, have higher levels of complications, cost, and showing minimal improvement to outcomes over a balloon pump. Now, given the continued number of publications and increasing global use of the device, the balloon pump is expected to remain the mainstay and first line of mechanical assist in the near future. SHOCK 2 adds more information to our understanding of the balloon pump, but alone is not sufficient to change practice. We need more meta-analysis. We need a broader scope and a broader inspection of all of those RCTs to really get an idea of what we're seeing in the clinical changes before we start to change our practice. While it represents an important indication for balloon pumping, it is not the only indication for its use, and many experts agree that a balloon pump should remain that first line of defense when medical intervention fails to achieve the desired effect in our high-risk patients. Thank you so much.